You can see here at the bottom the echogenic debris, which is in this wall of necrosis, a diameter of nearly 10 centimeters. This patient also has splenic vein thrombosis, and therefore she has a lot of collaterals, which I will try to avoid during my puncture. So I'm using here the latest Pentax echo endoscope with a 4 mm working channel, and I'm using the Boston Hot Axios device. And with the RB AutoCut 5.0, it's purely cutting without any coagulation, so I will be able to advance directly into the Waldorf necrosis. I think now I'm in a good position. I'll double check that there is no vessel in the way. So now I'm actually able to advance the device into the cyst. So you can see I'm already deep in the Waldorf necrosis. Don't know if you can see it here. So now I advance the device as much as possible into the cyst, so there is no risk of dislocation. And now I can lock the device. You can see it here. So now with doing that, I reduce the risk of a dislocation. And now I can open the distal flange of the stent. And you can see here how nicely the distal flange opens. Now I will unlock the device and pull the distal flange close to the wall of the necrosis until it deforms the distal flange a little bit like a football. Now the next step, I will open the proximal flange in my echo endoscope. I'll apply some air and try to get some distance to the mucosa. And now I'll push the stent out of the probe. Now it's open. The stent is nicely open and a lot of fluid is already coming. So I have to suck all the fluid out. But I think, as you can see, the stent is nicely open and the cyst drainage is now performed without any bleeding or any complications. Usually it takes 24 hours until the stent opens up completely, and we'll give it that time to reduce the risk of bleeding, and then we can nice and easily perform the necrosis through the necrosectomy through the completely opened stent.